Hello, friends. I am Dr. Gaurav Gangwani, a board certified interventional radiologist, a minimally invasive surgeon. Today's topic is thyroid nodule ablation, how we can treat thyroid nodules or lumps in the neck in the thyroid gland without any surgery with the help of a needle with a novel technique known as thermal ablation. So, friends, if you have a lump in the lower neck, midline or paramidline, something that looks like this or this, it can be small, it can be large, sometimes as large as going from the jaw right up to the chest or inside the chest. Heavy chances are that you have got a thyroid nodule. A nodule or a mass in the thyroid gland, one of the very important endocrine glands of the body situated in the midline neck, which takes care of metabolism. But if you have this lump or you have already been diagnosed with a thyroid nodule, don't panic already. More than 90% of these nodules are benign or non cancerous. So many of them don't require treatment, and even the ones that do can now be treated with a needle. So, in this video, I'm going to take you across various topics about thyroid nodule so that you come to know everything about nodules, right from what they are, why they form, how are they diagnosed, and finally the treatment options. Also, we are going to talk about our previous experience in the social media awareness campaigns and how you can contact us. But if you want to straight skip to the thermal ablation part about the technique where we can treat these nodules with a needle without any surgery, then the timer is given in this video. You can straight skip to that timeline and you do not need to go through the entire video. Those of you who really want to stick across the entire content, stay with us. I'm sure you will learn a lot about this. So friends, let's discuss the first topic of the day. What is a thyroid nodule and why does it form? The thyroid gland is an endocrine gland in the lower neck, as we discussed. It's a butterfly shaped or a dumbbell shaped gland which exists in the lower midline with two lobes on each side and a central bridge or a connecting rod known as the isthmus. This gland is surrounded by a lot of critical structures which are very important for the body. Right from the strap muscles in the front, various cervical sympathetic ganglia, nerves, and important blood vessels which go to the brain and bring blood from the brain to the sides, the air pipe and the food pipe, that is the trachea and the esophagus behind, the recurrent laryngeal nerve which handles the vocal cords and the voice also behind. So as you see, there are a lot of important structures which surround the thyroid gland, including the parathyroid glands behind, which help in calcium metabolism of the body. The main function of the thyroid gland is metabolism of the body. So right from appetite to weight maintenance to bleeding and menstruation in females, and a lot more function. It is one of the powerhouses of the body which helps maintain metabolism. That is why if someone has hypothyroidism, you can very well see that they get a lot of weight gain despite not having a lot of food. On the contrary, if someone has hyperthyroidism, the thyroid hormones increase to a very high level produced by the thyroid. They can have many side effects of high metabolism like palpitations, anxiety, extreme weight loss, extreme hunger, and various other options. So now that we know what a thyroid gland is, let's discuss the nodule. So many times due to excessive growth of thyroid cells, these nodules form, which are like benign tumors. We know that there can be excessive growth of muscles in uterus known as fibroids or of the fat cells known as lipomas, just a similar mechanism. 90% or more of these are benign or non-cancerous due to various causes. We'll discuss them. Few of them, less than 10%, can be cancerous. Don't panic. Even if a thyroid cancer forms, most of these cancers are very slow growing, are curable if treated in the right time, and the cure rate is as much as 99% over 5 years. But the topic of today is not to focus on cancer. We will make many videos on it. Right now, we will focus on benign or non-cancerous nodules. Now, a subtopic that we will discuss is why do thyroid nodules form? Now, there are various causes not completely well established or understood, but one of the primary causes considered is micromineral deficiency. Few areas, yes, it can be iodine deficiency, but most areas where now iodine is sufficiently provided in the soil, water, or even salt, which is iodized, it can be due to micromineral deficiencies like selenium deficiency or zinc deficiency. And that is why taking foodstuffs rich in these materials is a good treatment option to prevent nodules or prevent them from increasing if they have already formed. There are other causes like autoimmune thyroiditis, where your immunity mistakes your thyroid to be an antigen or a virus or an infection and starts attacking it. There may be phases where the attack stops and the repair starts, And these phases of inflammation and repair cause these nodules, hyperplastic nodules, to form, and they are known as thyroiditic nodules. So, yes, thyroiditis can be one important condition. So, these are the two main hypotheses of why benign nodules form. Besides these, there are other reasons which are being researched, and we are coming to know more and more causes like pesticides or plastics, which have various compounds like bisphenol A or BPLAs, which can potentially cause these nodules. But I'm not going to go into those details today. Even estrogen imbalance or hormone imbalance is proposed to be causing this. But again, because even despite knowing the cause, we don't have a lot of treatment options for these. We will skip the cause right now and go straight to the treatment. So, enough for the cause already. Let's skip to the diagnosis and treatment. And I promise you, we will make a lot of videos on causes, on naturopathic treatments to prevent progression or formation in the future. So, if you have a thyroid, which nodule needs a treatment? Friends, population studies or autopsy studies say that thyroid nodules can occur as commonly as 70% of the population. So, out of 10 people, 7 people can have a thyroid nodule within them if tested on ultrasound or if checked on autopsy samples of dead people randomly. But not all require treatment. In fact, most of you, if your nodules do not grow in size, you might not even come to know that you have a nodule, because not everyone goes for a sonography neck in a health checkup. So, which nodules need treatment? If a nodule is non-cancerous, there are three primary reasons why we need to treat it. Reason number one, if it is large enough and causing pressure on the air pipe, on the food pipe, on the recurrent laryngeal nerve, the vocal nerve, because of which you are having difficulty in breathing, in swallowing food, in speaking, your voice has become hoarse, then definitely you need treatment. Reason number second, if you are cosmetically concerned because of the nodule is causing a lump in the neck which is cosmetically visible. People don't like it. You don't like to appear like that. So definitely we can treat it so that the cosmetic lump disappears and you are free of the apprehension. Reason number three is toxic nodule or autonomous nodule. So sometimes few people can have this nodule producing a lot of thyroid, because of which you can have the state that we discussed, a very strong hyperthyroidism and symptoms like anxiety, weight loss, excessive hunger, palpitations, and a lot more. So these are the three predominant reasons why we would treat a benign thyroid nodule. Now, let's say you do not have a cosmetic concern and your nodule is not large enough to cause pressure symptoms, neither hyperthyroidism. But if there is interval growth on serial scans, I would still treat it because I don't want it to grow to a proportion where it starts causing pressure symptoms, where the treatment can require multiple sessions and may be difficult. Why not treat it and kill it when it's small rather than wait for it to grow large and cause troubles? So for me, that is one fourth criteria where I offer this treatment to my patients, even if they do not have any of the three major problems. So if you have this lump and you know that most likely it's a thyroid nodule, what do you do? How is it diagnosed? So first phase, you have to go to an endocrine specialist or an endocrinologist. The places where this subspecialty is not available, you can show to a ENT surgeon, you can show to an interventional radiologist, you can show to surgeons. Many of these surgeons or intervention radiologists treat these nodules across various parts of the country because endocrinologists may not be available everywhere. But if you have a thyroid specialist or an endocrinologist, they would probably be the best doctors to attend you. The endocrinologist, once you reach them, will do a clinical examination, will take a detailed history, will do some blood tests where they will test your thyroid hormones. Most of you with nodules will have a euthyroid state. Your thyroid hormones T3, T4, TSH will be bang normal, because it's not necessary that if you have a nodule, you should have hyper or hypothyroidism. Most of you won't have any of the problems in the thyroid hormone production. They will do other blood tests like antibodies, anti-TPO and anti-TG antibodies, so that they understand whether there is a component of thyroiditis, whether your immunity is attacking your thyroid. They might do tests like thyroglobulin to just rule out any blood marker which raises suspicion of cancer being the cause of the nodule. So there can be various tests that they do, along with some general workup that they need to do. The next most common test that they will do is a sonography of the neck. Yes, a USG or an ultrasound of the neck, where the radiologist will scan your thyroid, will confirm if it's a nodule, one or many, will take the size and three dimensions of the nodule along with the nodule volume in cc or ml, and will finally give some morphological parameters or scores to the nodule characteristics, which will give us a cumulative thyroid score by an International American College of Radiology system, which helps us decide on what are the chances that this nodule can be cancerous. Based on all these tests, we decide whether we need to work up the nodule further. If there is any suspicion, we might go for a isotope scan in some cases, and we might definitely go for a FNAC, especially if the thyroid score is 3 or beyond, just to confirm for sure under microscope by a trained pathologist whether this nodule is cancerous or benign. So this is how the workup goes. You will have a OPD visit of a physician or a clinician. They will get some blood tests done, sonography done. After this, they may get a radioisotope scan done and a FNAC if needed. So let's say you have done all this treatment and the diagnosis that is made is a solitary benign nodule. A solitary nodule in the thyroid that is non-cancerous in any of the areas, let's say right lobe, left lobe, or the connecting rod, the isthmus. What was the conventional treatment for this? So friends, the conventional treatment for a nodule was a hemithyroidectomy, meaning that you can't go in and remove the nodule only or enucleate the nodule. So you remove more than 50 to 60% of the thyroid gland, because thyroid is one of the most vascular organs of the body. So that's safest to do. You remove 50 to 60% of the gland, maybe the entire right lobe and the isthmus if the nodule is in the right lobe, so that the nodule is out along with the thyroid. It can be sent for testing and further process can be taken. Now, this approach did have some issues. Problem number one, you're doing it for a cosmetic complaint. You are not comfortable with the lump standing there in the lower neck, but now you have a scar standing there. Of course, there are treatments where intraoral removal through the floor of the mouth or where laparoscopic treatments are done through the chest and there's no scar. But again, not every nodule is amenable to such treatments. Problem number two, it is a surgery after all. So there would be general anesthesia and associated side effects. There would be surgical issues. There would be a long recovery time. There can be pain. There would be ICU stay. So there would be problems. Problem number three, you are removing 50 to 60% of the thyroid. So a few of you might end up with permanent hypothyroidism, for which you might have to take thyroid medications for life. Along with that lobe, a lot of parathyroid glands may be removed, because of which you may also have to take calcium tablets for life, because now you have hypocalcemia as the calcium metabolizing glands are also removed along. Problem number four, there are potential complications of the surgery, which we touched upon in short. And one of them is a damage to the adjacent structures, which can include the recurrent laryngeal nerve, because of which you can have a voice change where you have a hoarseness of voice, which might be transient, get autocorrected in 3 months by physiotherapy, speech therapy, but which can be permanent also. And the fifth problem in today's day and age is a long recovery time, because of which you might have to take leave from your active job. And for many of you, that might not be an option or an acceptable alternative. So you might seek a better alternative with lesser recovery time. So because of all these problems, the world has been trying to search for answers. Korea, China, a few countries cracked it first. But since the last 2 to 3 decades, we now have a very strong answer, and the answer is thermal ablation. So now let's discuss the point where you all have been waiting for and come to this technique, thermal ablation. So as the name suggests, we use a needle. We enter the thyroid nodule under sonography guidance, where we puncture the nodule with the needle under guidance, of course. We connect the needle with a copper cable to a generator, which can be either a radiofrequency generator or a microwave generator. Earlier, laser techniques were also used, but I think more and more RFA and microwave is completely replacing it. There are studies to suggest that even one session of RFA or microwave is better than 3 sessions of laser. So I will be talking about RFA and microwave as a thermal ablation option and not much about other options. So coming back, you push the needle into the nodule, you switch on the generator, it creates heat, a very titrated small circumference of heat, by which you burn a small aspect of the nodule. Once you know that lethal temperatures have killed the cells in that zone, you just manipulate the needle back and burn another area. Once that's done, you manipulate it back, burn another area. So this technique is known as the moving shot technique, and by this, slowly and steadily, you can destroy the entire nodule. Smaller nodules can be finished in as much as 1 to 2 minutes of ablation time. Larger nodules, sometimes if they are giant, can take as much as 30 to 60 minutes of total time and more than 20 to 25 minutes of ablation time. But in trained hands with such a titrated form of energy and heat destroying the nodule step by step, it can be done in a very close titrated manner. There are techniques to protect the critical structures from the heat known as hydrodissection, where you inject fluid, separate this nodule away from these critical structures, and you ensure and safeguard the protection of these structures without any risk of heat damaging them. Once the entire nodule is burned, you just pull out the needle And wait, by every month, the nodule will keep shrinking, fastest for the first 6 weeks, persistently so for the next 3 to 4 years. And mostly by 6 months, you might have a volume reduction of 60 to 90% and a complete cosmetic improvement. Most studies say that if it's a small to moderate size nodule, the volume reduction can be as much as 99% to 100% over a period of 6 months to 3 years. So that is how good this technique is. Now, what are the advantages? First, no scar. So it's a needle based therapy like your FNAC. There's no single scar, not even a dot of mark that you will see beyond a certain time, maybe after 7 days itself. Benefit number two, it can be done under local anesthesia. While doing it, you are talking to the patient so that you can keep testing the patient's voice. If you feel there is any change and heat is reaching the nerve, you can immediately inject cold saline and steroids locally and reverse it so that the patient has a normal voice at the end of the procedure. Benefit number three, there's no surgery, no general anesthesia, so the recovery time is super low. You can be admitted for 6 hours, maximum 24 hours, leave the hospital, start your work the next day. So, no ICU, no prolonged hospital stay, and immediate discharge followed by immediate resumption of work. Benefit number four, negligible risk of hypothyroidism or hypocalcemia. So, today, when we are talking in August 2023, we have finished more than 350 to 400 cases and not one case of hypothyroidism post procedure because of the procedure itself. And benefit number five, which is a major benefit, that the chances of voice change or damage to the critical structures adjacent to it are very, very low. Whether it's Korean data, Chinese data, Turkey data, European data, US data now that many trials have started there, and my personal or Indian data of my colleagues, we have had a very low complication risk. Out of these 350 to 400 patients, I have had one patient who had a durable voice change for 2 months, which auto-corrected with some speech therapy, and we are happy keeping the risk as low as this. So we spoke a lot about thermal ablation, but is it just a logical and a reasonable, fancy, gimmicky concept? Is it really established? Is there research or evidence for it? So let's look at a few of the evidences. Today we have level 1 evidence and a lot of international guidelines which have formulated guidelines based on this level 1 evidence. We have randomized control trials, we have meta-analysis of multiple randomized control trials which prove how this technique, thermal ablation, whether it is radiofrequency or microwave, is completely legitimate. It is very efficacious. Most studies say the success rate is approximately 90 to 99% with a very low complication risk. Sometimes the major complication risk is as low as 0.1%. And based on these guidelines and literature, it has become the standard of care in many countries where this is the first line approach for treatment of thyroid nodules and the patient is not referred for surgery first. Only in cases where this is not feasible or the nodule is cancerous or this fails, only then few patients are referred to surgery. Otherwise, this is the go-to approach. While I'm speaking, we are showing you a lot of literature which you can go to sites like PubMed, like Google Scholars, Scopus, and various medical sites where peer-reviewed open access literature is there, and you can review these results yourself. Even in closed access journals, at least the abstract is available, summary of the results, and you can read them and understand what kind of a results can we expect. We will be sharing these same links across the description as well as the comment box as a pinned comment so that you can review them yourself. You don't have to search for it. And we will be doing this diversified over various countries, data from various countries. In fact, June 23 onwards, we have started taking our own prospective data, and the results within the first month itself are super promising for the initial patients who have availed this approach. As far as personal experience goes, I can tell you I have been doing this from the past 10 years or more, and the results are excellent. We have been able to help more than 350 to 400 patients till date completely prevent a surgery, and we have saved their thyroids and prevented all of those complications that we listed. All of these patients are over a surveillance program and we will be keeping a watch on them. But by year third, we can tell them that, okay, you don't need any further follow-up because everything is bang normal. The nodule is disappeared or become a scar, so we can completely forget about it. So we are slowly coming down towards the end of the video. It was a long video. Thank you for bearing with me.
Thank you.
What happens when a patient comes to me in the OPD? After I show them the animation on how ablation is done, and after they view a few of my videos where I've shown live ablation cases, explain what exactly goes on in the OT, what do I explain them about the procedure? So first, I explain them about the procedure itself, how it's done technically. It's done under local anesthesia. Everything is through a needle. After the local anesthesia is done, we use the antenna needle, either the RF or the microwave. We insert it into the nodule, connect it to the generator, and ablate the nodule step by step. The technique that we showed, the moving shot technique, that is how it's done. Before we start the ablation, we inject a needle and instill some cold saline or dextrose across or around the nodule so that we push it away from critical structures and there is no risk to these critical structures when you ablate the nodule itself. Post procedure, once the needle is out, my assistant will give a compression with the small gauze, and within 15 minutes, you probably would be in your ward where you will be instructed to use ice packs locally on the neck so that the inflammation is down. We may discharge you within 6 to 24 hours and give you instructions for usage of antibiotics and anti-swelling agents with painkillers for a few days, maybe 3 to 5 days. And then you send us a blood report just to understand if there is any reactive thyroiditis and hyperthyroidism. And that's it for most of you. After that, we give you instructions on how frequently you have to do the sonography and send us the reports so that we understand how good the shrinkage is and if we are having a clinical success. Now, let's understand what is the clinical success rate. See, technical success means I put the needle, I burn it, I come out, and I say that we could do it smoothly without any reason to abandon it. That's nearly 100%. I still don't remember a patient where I had to abandon it before completion. But clinical success means whether we achieved the volume reduction and the cosmetic improvement which we intended to. So, our objective definition of clinical success is a volume reduction of more than 50% in 6 months or a cosmetic score reduction by 2, meaning that the cosmesis is significantly improved from what it looked like at baseline, which is approximately 86 to 100%. So, we have seen clinical success rates across various studies from 90 to 100% nearly, meaning 9 out of 10 patients or 10 out of 10 patients get the benefit from this ablation. It all depends on the size, the type of tissue, the ethnicity, and various factors. So that's why let's even take a conservative number. It's 9 out of 10. So one patient out of 10, it may fail, clinically fail. We might not see the result that we intended to, but otherwise, 9 out of 10, it will be absolute success. The complication risk. So, are there any potential complication risks of this technique? So, in my experience, and as far as I reviewed data, the chances that you have a major complication like a recurrent laryngeal nerve damage leading to hoarseness of voice is as low as 0.3%. And even if that occurs, till date, whatever data is there, most of this is reversible. I have yet to see a patient who has had a irreversible recurrent laryngeal nerve injury which did not improve with speech therapy over a period of 3 months. There are chances of thyroid nodule rupture, luckily not had one yet, but yes, the thyroid nodule can rupture, causing or requiring medicines, occasionally a tiny surgical nick, microsurgical nick to remove that content which is extruded out of the thyroid capsule because the burnt tissue inflames early on and then starts shrinking. The recovery in the hospital, like we said, is as low as 6 to 24 hours. At home, it's zero recovery period. You can start your work right the next day. Let's talk about surveillance or the follow-up instructions. So like I said, at regular intervals, we will ask you to do sonography and send us the reports. For the first year, we will ask you to do it at 6 weeks, 3 months, 6 months, and 12 months. And after the first year, we can do it annually, maybe for 3 years, and then forget about it if it's completely treated. But these protocols can vary from hospital to hospital, institute to institute, or operator to operator. So you can follow your local operator for the same. Now, if we treat this, are there any chances of recurrence? So friends, if the nodule is large and I am slightly conservative towards few of the margins which are near the critical structures, despite hydrodissection, I will leave them unablated, maybe a 3 to 5% of the margin, especially the one close to the recurrent laryngeal nerve. And when the entire nodule shrinks, the 97% that is burnt, then I can ablate the remaining 3 to 5% in a second session because at that point of time, all that margin is now shrunk towards the center and it's no more close to the critical structure. So I can safely ablate it, not being conservative, being aggressive, destroying a few margins, and I would be good. I'll get a complete cure. So the recurrence after one session or maximum after 2 sessions for a small nodule is negligible. Once you burn the tissue, it should not grow back. But can there be recurrence in other areas? Except for the small failure rate which we discussed, which is mainly based on tissue elastographic properties where the nodule did not get ablated well and it can regrow. Non-local recurrence, meaning distant recurrence in another lobe or in another zone can occur if the body has a tendency or if the autoimmune phenomenon is ongoing. So definitely recurrence can occur in other areas, but that nodule hopefully should not recur. What about the cosmetic sequelae? So friends, like we discussed, it's a complete scarless technique. Because it's done with a needle, there is no practical scar that occurs. Till date, not seen a single patient whom I can identify where I did it from after a few weeks. Lastly, what's the cost of the procedure? It's super variable depending on the hospital, on the ward, on the country you do it from, whether it's reimbursed or not. So it's super variable. If I give you a rough estimate, if you do it in India at a decent hospital with us, the cost can vary from as low as 1.2 lakhs Indian rupees to as high as 6 to 7 lakhs in Indian rupees. So it all depends on where we do it, which ward category you choose, which hospital you choose, and various other factors. Now, lastly, some things about myself, my team, the places I work, my social media experience, and why I am starting this awareness campaign. So, friends, we realize that with time, the number of operators who are doing this ablation technique are increasing. We have a lot of data now, but still, 95% of the doctors or the patients don't know about it. Because of which, a lot of patients end up with a hemithyroidectomy or a total thyroidectomy and do not get to learn about these techniques: ablation, percutaneous ethanol injections for cystic nodules, embolization for hyperthyroidism or multinodular goiters. And because of this, many patients undergo surgery where they lose their thyroids and face all the issues that we discussed. That is why we had started our social media awareness campaign and educational initiative, but in Hindi language for our country first, over a period of 3 years. And during this time, where predominantly we have been active from 1 year, we have seen a huge growth. We currently in August 23 are having a base of more than 43,000 subscribers. Our videos have been viewed for over 70 lakh times. So we are very happy with this positive response. We have had patient calls from all over the country. We have had patients traveling in from US, Nairobi, Kenya, Belgium, Mauritius, to name Dubai and Middle East countries, to name a few of them. So we realized what is the potential of this awareness campaign and how the world is lacking this awareness and it needs it so that people can save their thyroids and avail benefits of these minimally invasive alternatives. So if you need to contact me or my team for further guidance or clarity on on this topic, for a customized guidance for your case, you can contact us on the above number. It's active on most weekdays between 9 a.m. to 8 p.m. It is active on WhatsApp for our international based users. You can personally message me on Instagram or Meta, and hopefully I'll revert within a period of 3 working days. We are showing the IDs right here. You can also email me on my email ID, and I am displaying it here for you. So I hope that you got a lot of benefit from this video. If we get good success on the video, good amount of engagement, good amount of viewership, and we realize that yes, many people are looking for this in the English language, which was a feedback given to us by a lot of our English speaking patients who came down seeing our Hindi video, but they got help from the subtitles that we had, and they recommended us to start this channel even in the English language. So if we feel that there is a user base which requires this, which is interested, which will benefit from this, we are going to make a lot of content. Our Hindi channel is full of content. We have more than 450 videos today, and we can slowly start raising the frequency of the English channel, maybe to at least half the number of videos. Here, we will talk about a lot of things, right from causes of these nodules to naturopathic treatments to prevent them, to live demonstrations of thyroid nodule ablation, demo purposes, demonstration on a dummy, how this technique is done, including the generator parameters and the instruments, various other techniques like percutaneous ethanol injection for cystic nodules to embolization for multinodular goiters, Graves' disease, hyperthyroidism, and various other stuff. So if you liked our content, just tune in, subscribe, click the bell icon so that you get notifications whenever I post a video. And I hope this video has benefited you so that you stay safe and stay empowered.